Welcome back to Healthcare for Teens, a channel dedicated to helping teenagers understand more about the different areas of healthcare. Today, we have with us Dr. Hugh Calkins, a professor of medicine at Johns Hopkins University and the director of the Electrophysiology Laboratory and Arrhythmia Service at Johns Hopkins. Dr. Calkins, thank you so much for being with us today.
Oh, it's my pleasure. I'm very happy to be here.
To start off this interview, I'd like to ask, when did you realize that you were meant to be a doctor?
Well, my decision to go to medical school was due to my parents. Both my parents were physicians. My father was a rheumatologist and then a geriatrician and chief of medicine at the University of Buffalo. And my mother was a physician. She worked part-time at a psychiatric hospital doing general internal medicine. So I was born in a medical family. There were 9 children. But it was clear that my folks loved what they did. They never encouraged me to go into medicine. Of the 9 of us, only 3 did, but I could see how much they enjoyed it. And so that was one factor. The second was in high school. At the end of high school, when I graduated from high school, I spent a summer working as a nurse's aide in a general hospital. And that was a wonderful experience, which gave me insight into the sort of what happens in hospitals, the collegiality, the camaraderie, it's the teamwork. And so that really confirmed my interest in medical school. So I think it was really those 2 things that made me decide to go into medicine.
And of all medical professions, why did you choose to become an electrophysiologist?
Well, that's a good question. I mean, when you go to medical school, you can pick anything you want. And so the first thing is to narrow it down to a broad specialty. And I chose internal medicine because I think you spend more time, like a surgeon. Internal medicine doctors interact with the patients more. You follow patients over many years or decades. I like getting to know patients and having that sort of a relationship. And I knew I didn't want to do pediatrics because pediatrics, you're little babies. It's very hard to interact with them on a way you can with an adult. So that didn't attract me. Surgeons, I mean, surgery is very, very interesting, but you do a procedure and then you're done with the patient. You don't have a long-term relationship. And you also have to depend on referrals from other physicians to get your patients. And I wanted to control my destiny. So anyhow, and both my folks were internists, so it was easy for me to pick internal medicine. And then you do your residency, and during residency, you have to decide if you're going to specialize, and if so, what. And that's where the faculty you interact with really play a big role. So for me, in medical school and residency, a physician named Leslie Fang, who was a nephrologist, was actually my hero. He was just a superb doctor, just remarkably bright, gave great talks, took great care of patients, wrote succinct notes, really masterful. I did research with him as a medical student, and I really wanted to grow up and be like him. So initially I was going to do nephrology because I thought nephrologists were just super great internists and doctors, and electrolyte stuff is very complicated. That was my initial plan. But then you rotate throughout all the medical specialties, including cardiology. And just cardiology seems so much more exciting. The combination of procedures, cath procedures, EP procedures, pacemakers, whatever, the nature of the problems interested me. And again, there were super cardiologists at Mass General where I did my residency, people like Adolf Hutter and Roma DeSanctis, just great sort of role models. And so late in the game, I said, to heck with nephrology, I'm going into cardiology. So that got me into Hopkins in cardiology to do my training. And my initial plan was to do heart failure. And I was going to do heart failure because at Mass General, there were several heart failure doctors that I really liked and respected, and I wanted to be like them. So I came to Hopkins to be a heart failure doctor. But then when I was here, I did rotations on electrophysiology, arrhythmia service. And a physician there named Joe Levine, who works in New York, was my attending the month I did the rotation. And he basically gave me a sales pitch. He said, EP's going places. It's a new field. It's the way to go. He really sold it as a very exciting area. And it was really based on his encouragement that I backed out of heart failure and went into electrophysiology. And I've never looked back. It turned out it was a super choice. Heart failure wouldn't have been bad either. That's turned out to be a very good career path for cardiologists with lots of interesting, research and clinical problems. But so it's really about the people you interact with and how they influence your view of the world. And the nice thing is you don't have to decide when you're 18 what you're going to subspecialize in. It's a stepwise process.
What does an electrophysiologist do?
An electrophysiologist is the electrician of the heart. So you take care of anything related to the heart rhythm. So there's slow heart rhythms, sick sinus syndrome, heart block, bradycardia, things that you treat by putting a pacemaker in. There's fast heart rhythms like sudden cardiac death, ventricular fibrillation, ventricular tachycardia. There's other arrhythmias like atrial fibrillation, which is an upper chamber arrhythmia. So you're the electrician. And the really nice thing about electrophysiology, it's a nice combination of procedures and clinic time. So I spend 2 days in clinic seeing patients, usually about 25 patients a day. And then I spend 2 or 3 days a week doing procedures like catheter ablation, pacemakers, defibrillators. So you get the best of both worlds. Like a surgeon, you do a procedure and a patient says, thank you, you've cured them or treated them. And like an internist, you get to know patients over decades, in the clinic situation. So it's a wonderful part of cardiology. It's also growing exponentially as the population ages and gets more obese. More people get arrhythmias. So there's tremendous need for electrophysiologists in the world.
How do you diagnose and treat an arrhythmia?
There's a number of ways to diagnose arrhythmia. The main, it starts by getting an EKG. If someone's having an arrhythmia when you're seeing them, an EKG will diagnose it. Otherwise, you're looking for what's called a symptom-rhythm correlation. If someone's getting lightheaded or having palpitations or having heart racing, if you can catch that event on an EKG monitor system, a patch, or some kind of monitoring device, so you can actually see the arrhythmia start and stop, you can figure out what it is. So we use lots of Holter monitors, event monitors, things you put on for a day to 2 weeks to a month in a patient's chest to record their rhythm continuously. We also do electrophysiology studies where we put catheters in their leg and thread them up to the heart and evaluate the electrical system with a number of maneuvers and measurements. So there's a variety of ways that we diagnose arrhythmias.
I learned that heart disease is the leading cause of death for most racial and ethnic groups, contributing to about a fourth of U.S. deaths every year. What would your advice be to teenagers so that they can adopt early on in their life and stay healthier?
Oh, I think the number one, a couple of things are critical. Obviously, don't smoke cigarettes. That would be crazy. I won't call it suicide, but it's just a terrible thing to do. My mother was a smoker despite being a physician, and she ended up on oxygen before she died, and it's a terrible way to go. So whatever you do, don't smoke. So I think that's number one. Number two is don't get obese. If you get really fat, you're much more likely to get all types of arrhythmias, heart failure, all kind of cancer, hypertension, diabetes, you name it, you're going to get it. So body weight is important. I think the third is don't drink excessively. Alcohol can trigger arrhythmias. It brings on calories. So I'd say limit alcohol consumption. It's fine to have social drinking, but in excess, it's bad. So I think those are the three main things. It's also good to stay active, but things like triathlons and marathons aren't good for your health. What you need is like 30 to 40 minutes, 3 to 4 times a week of exercise is all that's recommended.
What does a normal day at work look like for you?
Well, it depends if it's a clinic day or if it's a procedure day. For a clinic day, my clinic starts at 7:30 in the morning and runs till about 5 p.m. And it's nonstop. Every 20 minutes, another patient, no lunch, racing from room to room to room. It's a very, very busy, packed schedule. Those are my toughest days. And the easier days are my procedure days. On procedure days, I get to the hospital at about 7 in the morning. I go say hello to the patient who's having the first procedure. We then have a morning group meeting to review all the procedures being done in the EP lab from 7:30 to 8. And then from 7 to 7:30, 7:30 to 8, and then we start the procedures. Each procedure takes about 4 hours, 3 to 4 hours. And then there's an hour or two between the procedures where you catch up on phone calls, emails, have lunch, that kind of stuff. And usually I'll do 2 to 3 procedures a day, and I get out of the hospital somewhere between 5:30 and 7 p.m. So they're long days, but they're interesting days. I no longer work on weekends. Earlier in my career, I would do call every 5 weeks. I'd be on call on weekends and that type of thing. But as time passed, I have my younger colleagues do that.
What areas of research are you involved in?
My two main areas of research is atrial fibrillation and catheter ablation of atrial fibrillation. AFib is the most common arrhythmia in the world. We developed the catheter ablation technique about 20 years ago for this arrhythmia, and we're constantly working to improve it. So that's my main focus. I've written hundreds of papers on catheter ablation. And the other is a disease called ARVD, which is an inherited condition that affects the proteins in your heart called the desmosomes, that results in sudden death and heart failure in young people. It usually shows up in high-level athletes as a teenager. There's an increased risk of sudden cardiac death. There's also a risk of developing heart failure. So we have the main program in the world working on that. I've written over 200 papers on ARVD. We started this program about 25 years ago, and it's been a very interesting disease to work on. And now gene therapy is being developed, so we're excited to be working on gene therapy trials soon.
Last but not least, what advice do you have for young people that aspire to become medical professionals?
Oh, one I would encourage you to do it. Medicine is a wonderful field. And what I like about it most is, one, the patients. I think it's interacting with patients on a personal level that are dealing with difficult problems or easy problems or whatever. So you get so much. It's such a unique opportunity and honor to interact with these patients and families. And second is your colleague and the community of healthcare providers. I mean, meta healthcare is a group sport. You have the attending physician, you have the junior physicians, you have the nurse, you have the PA, you have the technician, you have the phlebotomist, you have the radiologist. There's all types of roles and opportunities. And although, I obviously was lucky to go to medical school and end up being a physician, it's not that you can't have a super career in other components of healthcare. For example, nursing. There's a huge shortage of nursing. If you're a nurse, what's nice about being a nurse is you work, good and bad, is you work shifts. So if you're a nurse, you can work 10 hours a week, and that's considered full time. So if you have a family and want time when you're off and time when you're on, if you're a nurse, you can control your schedule. When your kids are young, you can cut back and ramp up later. And also, there's all these opportunities for nurses to climb up leadership trajectories in hospitals, to be the chief nurse. In the case at Hopkins, the president of the hospital is a nurse. So there's no limit to where you can go. Another interesting healthcare profession is being a mid-level provider, either a PA or a nurse practitioner. There you're basically a physician extender. You're like the doctor, but you're always working under someone else's license. So you don't have, the breadth of knowledge and freedom that a physician has, but you're very close. And like being a PA, it's just 2 years of school. You go to college, get some experience as an EMT or something else, and do 2 years of PA school. Then all of a sudden you have a very good job where you're working with a team of physicians. You're making a pretty good salary. Again, you have an hourly schedule, so when you're off, you're off. You have radiation technologists in the EP lab that work with us. You have nurses and technicians that work on implantable devices, pacemakers, anyhow, there's all kinds of interesting things to do in healthcare professions. And I think what's nicest about it is, one, you have tremendous job security. It's inherently interesting. You're helping people. You're working as part of a team. All those things are wonderful. you won't become a millionaire unless you start a company or do something different. If you're just a physician or any of the healthcare professionals, you aren't in it for the money. You can make a lot more money as a venture capitalist or some financial tycoon. But I think you'll have more fun in the healthcare profession. So I would encourage it. And I would, if you know people in the healthcare profession, spend time with them, shadow them, go see what their day is like, ask them questions, and also be open-minded. It's great to be a physician, but there's a lot more. There's many more health careers, the health field, jobs you can have in the healthcare field other than a physician. And I'll make one other comment. Being a physician is terrific, but it's a huge amount of effort and work. It's hard to get into medical school. When you're in medical school, it's a huge amount of work. You get out of medical school and then you got to apply for a residency. If you become a subspecialist or you're a fellowship, and so forth. And each time you have to apply, you may have to move. It's disruptive to the family. The hours are long. The pay is poor when you're in your training phase. So it's not an easy journey. So it's only worth doing if you love it, if you have a passion for it, and it brings you great joy and satisfaction. If you're just in it for the money, you're going to be disappointed and it's not going to be worth it. So I think if you love it, I love it, do it. If not, there's many other healthcare fields you could think about.
That's it for this video. And Dr. Calkins, thank you so much for the opportunity to interview you.
Well, thank you for the opportunity. It's a pleasure being here. And I hope everyone considers a healthcare profession. It's a great way to go.